if you look at this diagrammatic chart of scaphoid non-union, you realize that we may not always be talking about the same entity. There may be a proximal pole, there may be waist fractures with arthritis or without arthritis. There may be fracture non-unions with problematic arthritis or carpal instability. Diego Fernandez, who's in Switzerland, came up with a very nice approach to think about these things. And one thing we just touched on is a fibrous non-union. And when it's stable, without deformity, without collapse, these have an excellent prognosis, and grafting is not always necessary. And if grafting is considered, it's not necessary to be structural. Once you start having a larger defect or mobile non-union, even those that may have a pseudarthrosis, these may have an instability pattern, and anterior grafting may be able to not only reduce the malalignment, but also provide a structural or non-structural graft, as we'll touch upon. Once you start getting this position, as Dr. Blazer showed, we start having more problematic, and we have to start thinking about the age and the symptoms with carpal arthritis developing. And as was touched on, and Kyle Bickel will talk about this more, is there a need for a revascularization trial for some of these very proximal pole avascular situations? I'll try to stay with the non-vascularized grafts, and Kyle will talk about vascularized and other alternatives for this. So let's look at the waist fracture level. It's well-aligned, a CT scan, and no cystic changes. And this really is well handled with a non-structural graft. This is a young man with a typical presentation 6 months after an injury, and pain and limited motion in his wrist. And his x-rays showed exactly what Dr. Blazer was showing, where there's a suggestion of avascularity or radiodensity, but rarely are these truly avascular. And you can see on the CT, there's a little bit of a dorsal osteophyte, but the alignment is reasonably within normal limits, and another CT view. And so this is approached through a dorsal incision, and not only identifying the non-union, but decorticating with a small drill or K-wires on both sides to induce osteogenesis from the bones themselves. And I've never believed in this punctate bleeding situation per se. And then packing this with cancellous graft. And you realize that this is a three-dimensional deformity, so you can get a lot of graft in, and it will fill very nicely all the surfaces of the non-union. And then a headless screw placed, and here's your picture. And notice the radiodensity early on, but it does heal. There's a little radiolucency around the screw distally, but a functional outcome. We've also realized that treating a deformed non-union with a humpback can be done also without structural graft. And this is an article in Mark Cohn and colleagues in the Journal of Hand Surgery. I found that if you take a small syringe and take out the plunger and put in your cancellous distal radius graft and then compress it, you can then come out with a fairly compact compressed cancellous graft. And as illustrated in this case, the realignment is done and a very stable headless screw is placed. And this graft is filling the entire surface of the deformity. Once you start getting cystic changes and a humpback deformity, then we start to find the role of corticocancellous bone and a volar approach, whether using stretch of either distal radius or iliac crest, so-called Rusi graft, or a wedge graft taken from the distal radius will achieve this reasonably well. Realize that in these deformed non-unions, they may be, as described by Stephen Villegas, a volar type or a dorsal type. So it may be different, and that's why CT, as Dr. Blazer said, is critical in analyzing these. The advantage of this is that you not only are restoring the anatomy, but hopefully realigning the carpal kinematics and maybe slowing down the progression for osteoarthritis. The standard approach in many books has you paralleling the flexor carpi radialis and cutting straight across the volar radial scaphocapitate ligaments. But in trying to avoid that, Mark Garciolitis came up with this idea of creating two flaps. And then by doing this and closing them in sort of a Z-plasty fashion, you may have less traumatic injury to those ligaments. So here's a volar type classic deformed non-union, and taking out the deformity and creating a space, as Kyle Bickel talked about, for the graft is paramount in getting length and stability. And I agree, it's not absolutely necessary always to use headless screws. K-wires can be very effective in these cases, but once you've got the structural graft, it may be very stable. This is a case, you see this type of non-union, and opening this up and creating a big void, decorticating both edges so that there's healthy surfaces, and reducing it by extension, ulnar deviation, and bear in mind that there may be a rotational deformity of the distal half. So sometimes you need to do a rotational control, placing the graft, and here's your K-wire, and then headless screw. And a final case with a carpal instability pattern, the volar approach here. Again, decorticating, opening up and realigning the distal half and placing a wedge graft in, which is a fairly robust amount of bone, headless screw, and then a careful repair of the volar carpal ligaments. And here the realignment of the carpal situation as well. So if we look at the best evidence in the literature, both wedge structural graft and non-structural graft, both are reproducible with moderate evidence, good outcomes. And it doesn't appear to have a difference in the union rate between the two grafts types. Structural grafts will help you correct the carpal malalignment better than the non-structural grafts, and may be associated with the better functional, although the evidence is low. But long-term findings suggest neither these approaches will prevent OA, but may slow it down. In my experience, 90% of cases, including those with so-called scant bleeding points, have healed with interpositional graft and stable internal fixation, putting it only about 10% that require a revascularization procedure. And especially, as Dr. Blazer pointed out, bone vascularity has not really been identified very well in clinical reports, and it's very hard to really appreciate the effectiveness of vascularized graft compared to conventional techniques. Thank you.